Good afternoon to all SARS members. I welcome you all to today's second online clinical meeting. Today we have 6 interesting cases from the Department of Surgery, Medicine, Ophthalmology, Dermatology and Anatomy, and one e-presentation, e-post presentation. So today's first speaker is Dr. Sabita Reddy, PG Medicine, Surgeon. She is presenting empyema thoracis, the role of open thoracotomy with the decortication in the era of VATS. I have, please.
We have a technician.
Good afternoon, everyone. I'm Dr. Samita from Department of Surgery. I'm presenting a paper on empyema thoracis, the role of open thoracotomy with decortication in the era of VATS, under the guidance of Dr. Vikram sir, Dr. Tejaswini ma'am, Dr. Ranvi Patil sir, and Dr. Girish sir. Empyema thoracis is the collection of purulent fluid within the pleural space, that is between the parietal pleura and visceral pleura. It is one of the complications of pneumonia, usually caused by bacterial infections. In Western countries, usually gram-positive bacteria predominate, but what we see here in Northern Karnataka is mostly tuberculosis. And in pediatric patients, sometimes they present with gram-positive bacterial infections. Patients present with lower respiratory tract symptoms like fever, productive cough, and breathlessness. Initially, disease starts as an exudative effusion, progressing into multiloculation, and later it forms a thick layer of inflammatory exudates coating the viscera and further leads to fibrosis and lung collapse. Morbidity is significantly increased as the disease progresses from effusion to lung collapse. So earlier the intervention, better is the outcome. Modalities of treatment ranges from needle aspiration, intercostal tube drainage, surgical intervention like VATS, and thoracotomy decortication. While the whole world is moving to minimally invasive procedures, does it mean that thoracotomy decortication is obsolete? But what we see here is patients presenting in late stages of tuberculosis. Hence, what we conclude is that thoracotomy with decortication might still be an effective method of treating this condition. Materials and methods. This is a retrospective study conducted in the Department of Surgery from May 2015 to August 2020. Patients diagnosed with empyema thoracis who underwent thoracotomy decortication, VATS decortication, or VATS was converted to open were included. All the patients who were diagnosed with empyema thoracis but were treated non-surgically were excluded. The study period was from May 2015 to August 2020. Patients with duration of 3 weeks or less underwent VATS decortication, and more than 6 weeks underwent thoracotomy decortication. Between 3 to 6 weeks of duration of disease, it was left to the discretion of surgical team. All the surgeries were performed by the same team of surgeons. Total of 47 patients were included in our study, and various factors were including age, sex, duration of symptoms, etiology of the disease, post-operative and pre-operative complications, conversion of VATS to thoracotomy, everything was studied. Results. Duration of symptoms from the time of onset to the presenting to our hospital. Most of the patients had more than 4 weeks of symptoms, that is 45%. And most common etiology was tuberculosis, presenting in 39 patients. One patient had fungal mucormycosis, and one patient presented with mesothelioma. Preoperative bronchopular fistula was present in 15 patients, and almost 27 patients had more than 6 weeks of duration of disease to the time of surgical intervention. Uh, Thoracotomy decortication was done in 28 patients. VATS was successfully completed in 8 patients, but VATS was converted to open thoracotomy in 11 patients. Postoperatively, lung fibrosis was seen in 34% of the patients, and complete lung compliance was seen in 66%. Postoperative bronchopleural fistula was present in 17 patients, which manifested in less than 5 days postoperatively, and more than 10 days, 6 patients had bronchopleural fistula. Duration of hospital stay from the time of surgery, more than 51 patients stayed for 1 to 2 weeks. 21% of the patients were discharged in less than 1 week. These are a few pictures of the thoracotomy and VATS. The first two pictures show thoracotomy with decortication, complete decortication and lung expansion in a 30-year-old male. And the next two pictures are pictures of VATS done in a 9-year-old boy. These are the pictures of the 30-year-old male in whom open thoracotomy was done for left-sided empyema thoracis. Post-operatively, as you can see, lung fibrosis was present without complete expansion. This is the 9-year-old boy in whom VATS was done for right-sided empyema thoracis. Post-operatively, complete lung expansion with no bronchopleural fistula was achieved. Discussion. Many surgical techniques have been employed in the treatment of empyema, including debridement via VATS, decortication, thoracoplasty, and open window thoracostomy. Debridement via VATS gained popularity in mid-1990s, and its success rate ranges from 68 to 93%. Success range of VATS debridement very much depends on stage of the disease, and more patients in the organizing phase, higher is the failure rate. In our study, most patients are presenting in late stages, with tuberculosis being the common predominant etiological factor. Once an empyema organizes, adequate therapy usually mandates thoracotomy, with disruption of loculation, evacuation of pus and fibrinous debris, and decortication of expansion. In our study, 23% of the patients initially planned for VATS decortication were converted to open method due to thick corticate in the late stages or poor visualization. Decortication is the method of choice when underlying lung is unable to expand due to thick inflammatory coat and the patient is fit for major surgery. Decortication has shown to substantially improve the vital capacity and forced expiratory volume in the first second of breathing. In summary, early presentation of disease can be successfully treated with VATS decortication, but as the disease progresses to more than 3 weeks, the poor visualization and thick corticate, conversion of VATS to open thoracotomy for achieving complete decortication is significant. In conclusion, in late presentation and long-standing empyema thoracis, open thoracotomy still remains gold standard in achieving complete decortication. These are my references. Thank you.
Now the topic is open for discussion.
In one case, there was mesothelioma. You go through the report, what was done for that patient?
Yes, sir. For him, open thoracotomy was done, sir, for that patient. And
Further treatment
further treatment, we have sent the patient for radiotherapy. And follow-up, the patient did not turn up for follow-up afterwards. Like,
what the practical bad thing is related from that of
practical difficulty. Sir, like the working space is less in pediatric patients.
what the
Port size 5 ports, sir, and camera port 110 and whatever, if we have previously put the ICD through that port, usually we try to visualize the
port can be there.
ICD.
size of the port type, port smaller,
3 mm.
5 port only is
Or if there is no question, thank you.
Thank you.
And now I call second speaker, Dr. Vidaja from PG in Medicine. The topic of presentation is use of clock and star drawings as a marker of neuropsychological assessment in the grading of hepatic encephalopathy and compare with the West 7 criteria and photo-systematic encephalopathy score and index.
Good afternoon. Today my topic of presentation is use of clock and star drawing as a marker of neuropsychological assessment in the grading of hepatic encephalopathy and compare with Westhaven criteria and photosystemic encephalopathy score and index under the guidance of Dr. Malana S. Mulimanisa. Need for the study: hepatic encephalopathy, the commonest complication of cirrhosis of liver occurring in 50 to 70% of the patients, is a poor prognostic indicator with projected 1 and 3 year survival rates of 42 and 23% respectively without liver transplant, and has detrimental impact on quality of life. Even in cirrhotic patients who have a normal neurological examination, neuropsychological deficits have been shown in up to 84%, highlighting the potential for major neurobehavioral effects of the disease. Constructional apraxia is a well-recognized manifestation of hepatic encephalopathy, and the degree of constructional apraxia may serve as a simple, objective, and reproducible tool to grade the hepatic encephalopathy. And the grading is necessary to understand the evolution of disease as well as the response to our treatment. Hence, the use of clock and star drawings, which depict the level of constructional apraxia, as a simple bedside method of assessing the grade of hepatic encephalopathy. Objective of the study: to grade the hepatic encephalopathy with the help of neuropsychological tests like clock and star, and compare with the standard methods of grading like Westhaven criteria and photosystemic encephalopathy score and index. Materials and methods: it's a cross-sectional observational study done from November 2018 to June 2020. 50 patients diagnosed with cirrhosis were graded according to the Westhaven criteria and photosystemic encephalopathy index, and their degree of constructional apraxia is judged and scored by star and clock drawings, and these are compared. Patients with clinical and sonological evidence of cirrhosis are included in the study, and patients with acute liver cell failure or those comatose or having an alternate non-hepatic cause for low sensorium, such as hyponatremia, sedative overdose, acute alcohol intoxication, uremia, and hypoglycemia were excluded from the study. This is the Westhaven criteria we were talking about. According to the neurological manifestations of the patients are graded as 0 with normal behavior, 1 with short attention span, 2 with disorientation, 3 in a semi-stuporous condition but responding to noxious stimulus, and 4 comatose patients. The comatose patients were excluded because they are not able to draw. This is a photosystemic encephalopathy score which we used. It is given by the mental state as discussed earlier. Trail making. For trail making component, the patients were asked to connect a series of 25 arbitrarily arranged numbered spots in sequence, and the time is measured in seconds. Asterixis is the flapping motion which is usually seen in hepatic encephalopathy patients. Venous ammonia, which is measured in milligram per deciliter, and EEG. EEG is not a routine investigation done for the evaluation of hepatic encephalopathy, and it was not performed because the photosystemic encephalopathy is also not affected by the removal of EEG. The photosystemic encephalopathy sum is given by 3 into mental status score plus trail making score plus asterixis score plus ammonia score. and the index is given by the obtained sum divided by the highest possible sum. As the comatose patients were excluded, the highest possible mental score was 9, and the sum ranged from 0 to 1, and the index ranged from 0 to 1. There is no gold standard diagnosis for hepatic encephalopathy, so we have taken two criteria. One is Westhaven criteria more than 0, and the photosystemic encephalopathy index more than or equal to 0.33 in the setting of underlying cirrhosis, and other causes of altered conscious state were excluded. This is the scoring system used for STAR. It is given by for the first time in CMC Vellore by Edwin and et al. In 2011. It is used for grading the hepatic encephalopathy. 0 is used for those who are unable to draw. 1 who scribble like as shown in the figures. 2 able to draw lines but unable to connect sensibly to form a desired figure. 3 able to draw but imperfect. 4 is a perfect star. This is a scoring system used for clock, which is given for the first time in 1900s for the soldiers affected by the head injuries, mainly the occipital and parietal regions, which cause the visual spatial agnosis or the constructional apraxia. Score 0 is given for non-recognizable drawing of Ross distortion of the basic gestalt. 1 is given for the clock should contain approximately circular face or numbers 1 through 12. 2 clock should contain 2 of the following: a circular face or numbers 1 through 12 or symmetric number placement. 3 is near perfect representation of the perfect clock. My observations are the most common cause of cirrhosis in our study was alcohol with a mean age group of 45 plus or minus 11 with male preponderance, and there is statistically significant association present between clock and star drawings, each with Westhaven criteria as well as photosystemic encephalopathy index. The crystal values had shown the mean PSCI or the photosystemic encephalopathy index has decreased with each of the clock scores as well as the star scores. There is no overlap between the scores. And these are some of the pictures of clock drawings which were obtained in our study. 26% had score 0, 14% had score 1, 34% had score 2, and 24% had score 3. These are the star drawings seen in our study. 4% had score 0, 20% had score 1, 26% had score 2, 28% had score 3, and 22% had a perfect drawing of star 4. The sensitivity obtained is 88 for clock and 90 for star. Both combined has a sensitivity of 76. Specificity is 55 each for clock and star. Combined has 71.43. Discussion. Comparison of mean age among different studies have shown the mean age in our Indian studies is 40s, whereas in outside the India it is 55, suggesting a higher burden of cirrhosis in our country. Comparison of gender frequency among different studies have shown male preponderance. Common etiology of most common etiology of cirrhosis in our study was alcohol related, followed by viral etiology in coherence with studies by Paki et al., Mukherjee et al., and Ahmed et al. In our study, clock and star each had shown significant association with Westhaven criteria and photosystemic encephalopathy, similar to study done by Edwin and et al. The sensitivity and specificity of star and clock in our study was 90, 88, and 57 and 57 respectively, whereas sensitivity and specificity of star and clock in our study done by Edwin and et al. was 77, 85, 70, and 80 respectively. This may be explained by smaller sample size in our study. Conclusion: these are valid tests because the worsening of the drawings is observed with the worsening of the hepatic encephalopathy, the sensitive and specific tools. The clinical assessment is subjective, whereas these drawings provide an objective measurement. These are bedside, simple, less time consuming, and inexpensive, and they are repeatable. Like the drawings serve as documentary evidence which can later be assessed by other individuals as well. So it could be recommended to assess the severity of hepatic encephalopathy on a routine basis to understand the effect of treatment. Bibliography.
Any questions?
Made a very long pedal, a very long pedal, short and speed. They have written the comparison for the scoring aim and objective. The table would have avoided it.
Dr. B.S. Kadkar. He is a research scientist in genetic laboratory department of anatomy. His topic of presentation is clinical and experimental study on gene syndrome.
Good afternoon, everybody. Today I'm going to present our one of the case study on Klinefelter syndrome. Okay, first you come to the today I'm going to present one of the case study which we have analyzed in our human genetics laboratory. Okay, this is nothing but Klinefelter syndrome. What do you mean by Klinefelter syndrome? As you all know, Klinefelter syndrome is a chromosomal disorder which is having a one addition of X chromosome in the males. That is normal, you can see 46XX and 46XY. But here in this case, Klinefelter syndrome, the presence of the one addition of the X chromosome. So when it is we seen, one of the, as I told, Klinefelter syndrome. So the interesting case was first described in 1959 by the Jacobs and his team with the symptoms of tall structures, small testes, gynecomastia with presence of one extra chromosome. Along with these symptoms, hypogonadism, gynecomastia, and infertility are common symptoms in the Klinefelter syndrome. So all these symptoms are due to poor diagnosis and the lack of clinical care. So treatment in India. When you see these are all symptoms we cannot recognize during the diagnosis because of the poor diagnosis in Indian health system. So hence we report such rare case of the Klinefelter syndrome in our hospital and in our lab. So when you come to the clinical history, so the patient was 20-year-old male, married male, was admitted to our hospital with the history of weakness since 5 days, along with the pain of left lower part with thigh. He was born of non-consanguinate marriage parents. He was neither on any medication nor did have history of diabetes and the hypertension. So he is not a diabetic, he is not a BP patient. There was no family history of same. He had past, but he had the past recurring fracture of the long bones on leg. So on physical examination, his height is 155 centimeter, weight is 50 kg, 58 kg with gynecomastia, with gap in toes. Female pattern of hairline with the chest can be seen. Also on examination, left lung deformity with swelling was present. These findings were suggestive that testosterone deficiency syndrome with the male infertility. So along with this patient was referred to our human genetics laboratory for cytogenetic analysis. When you see the biochemical analysis, serum testosterone levels were very low, while the reference range should be 0.05 to 13.5 nanogram, but his case is 0.05 nanogram. When you see the serum ultra-sensitivity was normal range, when we done the karyotyping, it shows that presence of one X chromosome. These are the one figure as so is the patient, and the one X-ray is showing that left leg deformity with swelling was present. And when you see the chest, small black color hairline is there. When you do the third figure, it shows the metaphase stage where you can see it is not a 46XY, it is a 47XY. These are the karyotyping analysis was done. Figure 3. When you come to the discussion part, so Klinefelter syndrome, when you come to the incident rate, 1 in 600 in male birth. Approximately 64% of the cases were undergone without, with 64% approximately, which remain undiagnosed throughout life. So Klinefelter syndrome is also genital abnormalities associated with neurocognitive abnormalities, which recently discovered in the 20th century. Although damage to testes initiated in utera in patient with Klinefelter syndrome. So our patient has 2 children from his early marriages, but he's become infertile due to accelerated testicular damage. So in case of adult men, when you see commonly observed symptom with gynecomastia with psychological stress, these Klinefelter syndrome cases were confirmed by the cytogenetic analysis, that is banding technique, and the molecular cytogenetic analysis, that is fluorescent in situ hybridization. So in our study, we observe infertile with male with 47 XXY character. When you see, if we suggest further analysis, that is fish analysis or a chromosomal microarray, the patient is not affordable to go through because of the economics. These are my references. Thank you.
Any questions?
Primary infertility is more or secondary infertility is more in Klinefelter?
Primary, sir.
Theoretically. But in this case, it was
It's secondary. Yes, my early marriages, sir.
What is the rate of incidence?
1 in 600, sir.
1 in 600.
Out of 600, one should be having this.
not too rare.
Not
Not too rare.
but 64% are undiagnosed. Until 18th age, they don't know the things, sir. Until 18th age.
Is the first case reported in your laboratory?
Yes, sir. Klinefelter.
Only case.
Only case. We done Downs, Turner, and all, sir. This is the one.
Again, this has to be confirmed by
Fish.
or no need.
No, first fish or chromosomal microarray, sir. But the patient is not offered to because he is economically very low.
Oh, thank you. Now I call the fourth speaker, Dr. Nusha from the Department of Dermatology. Her topic of presentation is the eco-mycological study of dermatophytics as a tertiary care hospital, as in tertiary care hospital.
Good afternoon, everyone. I'm Dr. Anusha from Department of Dermatology. The topic for today's presentation is clinico-mycological study of dermatophytosis at the Tertiary Care Center, done under the guidance of Dr. Arun C. Namdar sir, Dr. Keshamurthy Adya sir, Dr. Ajit B. Jangon sir, and Dr. Niranjan Deshmukh sir. Dermatophytosis is a superficial fungal infection of the keratinized tissue. Dermatophytes are a specialized group of fungi causing dermatophytosis that affects the skin, hair, and nails. The evolution of dermatophytes is constantly influenced by the geographic and socio-economic conditions. The disease has a high carriage rate, thus affecting the majority of people and also leading to chronicity and frequent relapses among patients. The objective of this study was to determine the epidemiological trends of dermatophytosis among patients attending the skin OPD at Tertiary Care Center, and also to study the clinical types and its relation to lifestyle and occupation. It was a hospital-based cross-section study which was done by enrolling 384 patients, irrespective of their age and gender. A detailed history about the age, duration of the disease, occupation, socioeconomic status, and other relevant past personal and family history was recorded from the patient. The patients were then examined to determine the clinical type of dermatophytosis. The specimen for biological investigation was collected from the lesion, and it was utilized for preparing a 10% KOH mount for direct microscopy for visualization of the fungal hyphae. Irrespective of the KOH mount result, the specimen was also inoculated onto 3 medias, that is severous dextrose agar with and without antibiotics, and dermatophyte test media for the purpose of isolation of species. The results were as follows. The age of the patients ranged from 3 to 71 years with a mean age of 36 years, and the most commonly affected age group was 30 to 39 years, followed by 20 to 29 years. Out of the 384 patients enrolled in the study, about 67% were males and 32% were females, with the male to female ratio being 2:1. Farming was the chief occupation of this study group, followed by students and homemakers, and maximum patients presented with 1 to 2 months duration of lesion.
Display equivalent.
About 95% of the patients had history of either using a topical or oral medication, and only about 5% of the patients had no history of previous medication. History of similar complaints was present in 20% of the patients. History of similar complaints among family members was seen in 37% of the patients. History of wearing tight garments like leggings, jeans, and tying of sari or dhoti tightly was seen in 50% of the patients, and the tinea lesions were commonly seen to be present in areas prone for occlusion due to tight-fitted clothes, like along the waistline, groin, or intramammary area. Sharing of fomites was seen in 64% of the patients, and the most common site of involvement was groin region, followed by gluteal area, and the least common was beard area, followed by scalp. Most common clinical diagnosis was tinea corporis, followed by tinea cruris, while the least common were tinea barbae and tinea capitis. KOH examination showed the presence of fungal hyphae in 82% of the specimen. Positive growth for dermatophytosis on either of the medias was seen in 57% of the samples. Among the medias with dermatophytic growth, maximum growth was seen to be present on dermatophyte test media, followed by SDA media with antibiotics. The most common isolated species was Trichophyton mentagrophytes, which was followed by Trichophyton rubrum. The other species which was isolated was Trichophyton tonsurens and Microsporum canis. These are the clinical images of the study group. Figure 12 shows tinea corporis lesion along the baseline, and figure 13 shows tinea capitis lesion. Tinea faciae with raised active borders seen in figure 14, and figure 15 shows a lycomycosis of the middle and the ring finger. Figure 16 shows direct microscopy of 10% KOH mount showing highly long branching septate hyphae. Figure 17 shows white cottony growth of dermatophytes seen on SDA media. Dermatophyte test media prior to inoculation, which is yellow in color, and this being an indicator media containing phenol, turns to pink color with the growth of dermatophytes. And figure 20 shows microscopic morphology of Trichophyton mentagrophytes, and 21 shows microscopic morphology of Microsporum canis. The study highlights that the predisposition of infection among adults may be attributed to their greater physical activity, mobility, transpiration that aids in the proliferation of the fungus. The predominance of infection among males occurs as a result of their higher exposure due to their chief outdoor activity. Increased prevalence of dermatophytosis among farmers, housewives, laborers can be explained by the nature of their day-to-day work, leading to increased sweating, exposure to animals, unfavorable weather condition, and less awareness about the condition. Students are prone for dermatophytosis due to the result of sharing of fomites among roommates or hostel inmates, and also due to the habit of wearing jeans or other tight-fitted clothing, usage of occlusive wear, and negligent attitude towards the disease. The patient's heedless behavior, benign nature of the condition, and limited access to higher healthcare centers can be ascribed for prolonged duration of lesion and consultation. Most of the patients had history of self-medication, and only a handful of the patients had history of consulting a dermatologist. This can be attributed to the easy availability of many over-the-counter antifungal steroid combination creams, need for rapid relief from symptoms of dermatophytosis, and benignness among the patients. Inadequate, incomplete, and faulty treatment results in recurrence of the disease, which was evident in 20% of the study group. Dermatophytosis seems to have undergone a paramount change in its clinical pattern in the past few years, with larger vision, and increased body surface area involvement. Most common clinical diagnosis was tinea corporis followed by tinea cruris. This result was comparable with other large number of studies. The study also demonstrates the trend in epidemiological transformation of the most common positive organism of dermatophytosis from Trichophyton rubrum to Trichophyton mentectophytes. The clinical failure of antifungal therapy in patients with dermatophytosis can be attributed to the persistence of predisposing factors, lack of personal hygiene, poor education regarding the infection and its treatment aspects among the general public, and topical corticosteroids used in combination with antifungal agents, which are abused and being applied for weeks, months, or sometimes years, leads to chronic treatment-resistant dermatophytosis. Even though the problem of recalcitrant dermatophytosis is growing leaps and bounds in India, there is a large void in the published epidemiological, clinical, and laboratory research in this field. This clinical epidemiological study helps to clarify the determinants of the trends associated with dermatophytosis at a tertiary care center.
Any questions?
These are all whatever fungal stage we have done here.
Yes, sir. The samples which were collected here, which were sent to microbiology laboratory, and there they processed and accelerated the species.
Total
384, and percentage of culture positivity was 57% in my case.
Is there any family history?
Family history was seen in about 20% of the 37% actually. There also history of sharing of fomites can be the reason, and sometimes only 1% in the family will get the treatment. The others will be still having the disease and do not get the treatment.
Environmental factors play a important. Any genes?
Genes has such big.
What about incidence of dermatophytosis in diabetes?
So we saw there was no correlation as such. There was no significant association of diabetes or any other comorbidities with dermatophytosis. Immunocompromised patients had rather large body surface area involvement, but not like any association.
When you advise combination of antifungal with steroid,
We don't advise combination creams, sir. It is
when
all.
they are available.
It gives rapid relief from the itching or the symptoms. For which, sir?
Indication for having antifungal.
We don't give a steroid combination with fungal. We don't. It is usually mild. There are this one. Yes. We advise the patients as far as possible never to use such combination creams. Patients before coming here, only 5% had shown to a dermatologist. Others had taken most of it from outside. Thank you, sir.
Model.
I call upon now the official speaker, Dr. Sufi, PG Naftar. Topic of presentation is comparative study of frequent coronary tomographic analysis of macula in the pre-operative and post-operative diabetic patients undergoing small incision cataract surgery.
Good evening, everyone. Today's my topic for the presentation is comparative study of optical coherence tomographic analysis of macula in preoperative and postoperative diabetic patients who are undergoing small incision cataract surgery under the guidance of Dr. Vallabha. Introduction: diabetic macular edema is the microvascular complication of diabetes which leads to loss of vision. The underlying pathogenesis is disruption of inner blood retinal barrier, which leads to fluid and lipid accumulation in the central part of the retina, which is clinically seen as increase in thickness of macular area with a hard X-ray formation. Diabetic patients pose a great challenge when there is a diabetic retinopathy along with the cataract, which causes severe visual morbidity. So the risk of developing vision loss also depends upon the grade of diabetic retinopathy after the cataract surgery. After the surgical insert, there is a prostaglandin release and its association with the diabetic retinopathy, which might be the cause of macular edema after cataract surgery. The relative increase in thickness of macula, which is difficult to detect clinically, whereas OCT, which is a non-invasive modality, which is particularly useful in measuring the macular thickness. Hence, the study is undertaken to measure the macular thickness in diabetic patients who are undergoing cataract surgery using macular analysis protocol scans on Cirrus HD optical coherence tomography scans. The aim and objective of the study: to compare and analyze preoperative and postoperative OCT changes in macula of diabetic patients who are undergoing cataract surgery. Coming to the methodology, it is a prospective comparative study. The study duration is October 2018 to April 2020. Study participants were 65 patients. Inclusion criteria: diabetic patients with senile immature cataract with varying levels of retinopathy, including the absence of retinopathy included, and they were underwent uncomplicated small incision cataract surgery which is done by an experienced surgeon. Whereas exclusion criteria is diabetic patients where preoperative OCT is not possible, subluxated lens, pseudoexfoliation, glaucoma, intraoperatively any complications, diabetic patients with prior intraocular surgery in the same eye, uveitis, presence of any retinal or choroidal disease other than diabetes that could affect the retinal thickness were excluded. Coming to the preoperative evaluation, visual acuity is tested for distance and near using Snellen's distance chart. Diffraction correction were given wherever it is required. External ocular examination is done. Slit lamp biomicroscopic examination to know the grade of the cataract. Tonometry was done with applanation tonometer to check the IOP. Lacrimal patency test is done. Keratometry is done. A-scan and intraocular lens power calculation is done by SRK using SRK2 formula. Fundus examination is done with indirect ophthalmoscopy with using 20D lens. The level of diabetic retinopathy was recorded as no, mild, moderate, and severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, as described in the early treatment diabetic retinopathy study. Subject characteristics including age, gender, duration of diabetes, HbA1c, FBS, PPBS, RBS, and the medications used and the type of diabetes were recorded. Postoperatively, all the patients received a course of tapering dose of topical antibiotic steroid eye drops, topical neparmine as the NSID, which is given 3 times daily for 1 month. Systemic antibiotics and analgesics were given for 3 days postoperatively. And optical coherence tomography testing was repeated at postoperative day 1 week, and 4th week and 12th week postoperative visits. Best corrected visual acuity is recorded at each visit. Fundus photographs of retina were taken with the Canon CF1 digital retinal camera. Optical coherence tomography was done using Cirrus HD OCT scan. The testing was performed and images were generated with the use of macular tube scan, which is a 6 into 6 mm square bit according to the manufacturer protocol as described in the user's manual. The results: out of the 65 patients who were lost to follow, 2 patients in the diabetic retinopathy group had pseudophakic bullous keratopathy. So because of the hazy media, OCT scans were not taken. So therefore, 59 patients completed the 3 months follow. The mean age of the study population is 66 plus or minus 77.8 years. Among the 59 patients, 36 were males and 23 were females. Among the 59 study group, the type 2 diabetes mellitus patients, most of the patients with less than 5 years duration of diabetes are about 67% patients. Mean duration is 4.8 plus or minus 2.9 years. 32 patients were systemic hypertensives. 29 patients underwent cataract surgery in the right eye. 30 patients underwent cataract surgery in left eye. No diabetic retinopathy was detected preoperatively in 44% of the diabetic eyes. 18 patients had mild infedia. 30.5% had moderate infedia. 8% had moderate uncomparable. Severe infedia with macular edema is seen in 1 patient, and preoperatively Preoperatively, 93% patients had visual acuity of 6/60 or less. Overall visual acuity is improved at 4th and 12th week after surgery is 6/12 to 6/9 in majority of the patients. Whereas at the end of 1 month, 75% achieved a vision of 6/6 to 6/12. By the end of 3 months, 89.8% of patients achieved a vision of 6/6 to 6/12. So coming to the mean central subfield thickness on OCT of macular scans in patients of all grades of diabetic retinopathy, there is a higher statistically significant increase seen at 1 and 3 months postoperatively, whereas mean preoperative thickness was 267 plus or minus 16.9 microns. It increased to 285 plus or minus 42.2 at the end of 1 month, and at the end of 3 months, it is increased to 296.6 plus or minus 55.67, and this was statistically significant correlated with a p-value of 0.002. Whereas among the no diabetic retinopathy patients, they developed a thickening of almost 20 microns from preoperatively to postoperatively at the 3rd month, and it is also statistically significantly correlated with a p-value of 0.03. Whereas in patients with mild and moderate NPDR, there is less significant increase is seen in central subfield macular thickness, and it was mild increase. The rise in thickness was not statistically significant. Whereas in patients with moderate NPDR with preoperatively diagnosed macular edema had the highest increase in macular thickness with a mean preoperative value of 289.8 microns, with increase to 3 at the end of 3 months. It is increased to 406.3 plus or minus 77.2. It is also proved statistically significant with a p-value of 0.044. In conclusion, we have demonstrated that diabetic macular edema generally worsens after cataract surgery, and the worsening of macular edema is more prominent in eyes with patients with diabetic retinopathy. The change in patients without diabetic retinopathy is subclinical, and it doesn't have any effect on the visual acuity. So this is one of the patients who with a normal macular scan, which is seen preoperatively, where same patient developed at the end of 3 months, he developed increase in macular thickness. This is a diffuse kind of macular edema with the intraretinal system. Coming to the discussion, most of the studies in literature showed that central macular thickness is statistically significant increase at 1 month after cataract surgery, and it was maintained after 3 months, which points out a possible leakage. Also, baseline CMT was thicker in patients who are developing pseudophakic macular edema. It suggests that central macular thickness is the predisposing risk factor for the developing pseudophakic macular edema, or the presence of subclinical pseudophakic macular edema, which may not sometimes it may not be detected by the OCT imaging systems. Inflammatory mediators may also cause increased vascular permeability, which leads to increase in macular thickness and cyst formation. So nowadays, use of SD-OCT provides a more quicker, objective, and non-invasive assessment of retinal thickness compared to the fluorescein angiography. So compared to the time domain OCT, today's spectral domain OCT offers more accurate measurements, higher repeatability, and low rates of errors and false negatives. Whereas in other studies like Duker et al. Showed that SD-OCT has enabled ophthalmologists to visualize and monitor the vitreomacular interface with a better accuracy and the repeatability. So in this study, similar to other recent studies, OCT was used to evaluate the progression of macular edema following cataract surgery. So similar to previous studies which have reported the rate of macular edema progression from other methods such as fluorescein angiography, the proportion of eyes which manifest their angiographic cystoid macular edema was 9% after cataract surgery using fluorescein angiography without diabetes patients. In other studies such as Romero et al. Reported a 6% of diabetic patients among 132 eyes developed diabetic macular edema, which were evaluated on fluorescein angiography and OCT following uneventful factor investigation. In our study, the level of diabetic retinopathy was associated with the foveal thickness. The patients with no diabetic retinopathy developed a minimal increase of 15.22 and 21.2 at the end of 4th and 12th week of the surgery. The worse the level of diabetic retinopathy at the baseline, the more likely the foveal thickness increased at 4th and 12th week of after surgery. So the group with mild NPDR, they had 4.4 and 8.4 microns increase at 4th and 12th week of surgery. Whereas moderate NPDR patients with macular edema, they developed the largest increase in foveal thickness, that is 57.5 microns and 135 microns at the 4th and 12th week of the surgery. So in mild and moderate NPDR patients, it is not statistically increased due to small number of patients, but the increase in foveal thickness was correlated inversely with the visual acuity improvement. Whereas another study, Hayashi et al. Has shown the foveal thickness and macular volume in diabetic patient increases after cataract surgery. In eyes with and without diabetic retinopathy, the percent increase from baseline was greatest at 3 months after surgery, then it has decreased gradually. The increase in foveal thickness was greater in eyes with diabetic retinopathy than in eyes without diabetic retinopathy. So the results increase on average, diabetic macular edema worsens after cataract surgery, and the worsening is more pronounced in eyes with diabetic retinopathy. So our study also showed similar significant correlation between the level of retinopathy, foveal thickness, but our study is limited by the duration of follow-up of patients to know the maculopathy progression or regression as described by Hamish. Conclusion, our study shows that patients with diabetes need a preoperative characterization of the retinopathy before cataract surgery and advised about the risk of progression of retinopathy after surgery. To provide patients with diabetic retinopathy the benefits of cataract surgery and avoid the progression of macular edema, it is advised that all patients with diabetic retinopathy should be evaluated with OCT, particularly in the early postoperative period to detect the macular changes so that early diagnosis and adequate management can be ensured. So all diabetic patients need a close observation of at least 6 months following surgery to intervene with a laser photocoagulation or anti-VEGFs as and when required to prevent the visual loss from the diabetic maculopathy and other consequences of diabetic retinopathy. And optical coherence tomography has gained widespread popularity in the detection of macular edema, macular changes in various diseases. It allows early and accurate diagnosis and better follow-up. OCT is a safe, non-invasive and quick procedure which provides objective documentation of foveal, retinal and optic nerve head analysis. These are my references.
Any questions? First, we are ready for presentation. Is too lengthy. Huh? How much time you have taken? References that you have to put reduce your topic. Presentation.
Time management also
Time
important.
management.
Time.
Any questions? Thank you. Now I call the last speaker, Dr. Harshavardhan, PG in Medicine. His presentation is the estimation of serum uric acid level in newly diagnosed essential hypertension.
Good evening, everyone. Myself, Dr. Harshavardhan Narute. I'm from Department of General Medicine. Today's my topic is estimation of serum uric acid level in newly diagnosed essential hypertension under the guidance of Dr. V.G. Varat. Introduction. Uric acid is the end product of endogenous and dietary purine nucleotide metabolism. Swedish researcher still segregated it from urinary stone, and in 1997, British researcher Wallstone identified uric acid in topus, which was taken out from his ear. About 50 years later, Alfred Baring Garrod, a British physician, showed by chemical isolation that uric acid was abnormally high in Cauchy patients. And subsequent studies, Garrod formulated a rational relationship between hyperuricemia and symptomatology of Cauchy patients. In 1957, association between hypertension and raised serum uric acid was recognized when family with unique and unfortunate pedigree attended Hammersmith Hospital. A family including a father and six of 7 kin had hyperuricemia, while mother and all of the kin had hypertension. So these incidents raised the question whether raised serum uric acid level were common in patients with hypertension or not. Raised serum uric acid has been reported to be associated with increased risk of coronary heart disease, stroke, and is commonly encountered with essential hypertension. As regards blood pressure, Elevated level of uric acid have been identified as an independent predictor of hypertension incidence and its progression. It is well known that serum uric acid was associated with metabolic syndrome, which in turn related to endothelial dysfunction, vascular inflammation, hypertension, all of which may contribute to the atherosclerosis. Very recently, positive and significant association between uric acid and several inflammatory markers such as C-reactive protein, interleukin 6 and interleukin 18, tumor necrosis factor was found in a large population-based sample of older patients. Further, evidence suggests that uric acid might stimulate inflammation, which is clearly involved in pathogenesis of cardiovascular disease. Objective of my study was to study the association of the serum uric acid level with newly diagnosed essential hypertension. This study was conducted in Sri B.M. Patil Medical College from November 2018 to June 2020. It was cross-sectional study done in all patients that satisfy the inclusion criteria. Study subject, a sample size of 93 subjects will allow the study to determine the estimation of serum uric acid level in newly diagnosed essential hypertension. Inclusion criteria: all patients above 16 year of age with newly diagnosed essential hypertension of both gender will be included in study. Systolic blood pressure equal or greater than 140 mm of Hg and diastolic blood pressure greater than equal to more than 90 mm of Hg according to JNC criteria 7. My exclusion criteria was all causes of secondary hypertension, IHD, congestive heart failure, gout, hypothyroidism, hyperthyroidism, renal insufficiency, glomerulonephritis, pyelonephritis, hereditary nephropathy, and patient is on drug like levodopa, ethambutol, pyrazinamide like the ATT drug, a cytotoxic drug, low dose of aspirin, and thiazide diuretics. Observation and result. Total 93 patients were included including our study. Among that, male patients were 66, that is 71%, and female patients were 27%, that is around 29%. And most of patients, like about 3/4 of patients, fall in age group of 40 to 70 years. Among the studied population in male, serum uric acid level is 6.37 mean serum uric acid level. Mean systolic blood pressure and diastolic blood pressure were 163.9 and 93.94 mm of Hg respectively. In female, mean serum uric acid level was 6.03 milligram per deciliter, and systolic and diastolic blood pressure were 165 and 93.56 mm of Hg respectively. In a studied population, minimum systolic and diastolic blood pressure are 140 and 90 mm of Hg respectively, and maximum systolic and diastolic blood pressure were 200 and 110 mm of Hg. It was also observed that minimum uric acid level in study was 3.110 mg, and maximum uric acid level were 9.7 milligram per deciliter, and mean value of 6.24 milligram per deciliter. Total number of newly diagnosed gestational hypertension patients were 93, out of which hyperuricemia was seen in around 52% of patients, while rest of 44, that is 47.3% hypertensive patients showed normal uric acid level. In this study, among number of hyperuricemic patients were seen, most of patients in 41 to 50 years, accounting about 38.7. The association of above said parameter in combination of Sussman correlation coefficient was applied, and concurrently the p-value also observed. The association displayed significant positive correlation between systolic blood pressure and mean serum uric acid level. The same association was studied between diastolic blood pressure and mean serum uric acid level was found to have mild but statistically insignificant correlation. Discussion. In other studies like study done by Kinsley, around 46% of patients showed hyperuricemia. A study done by Kolbe around reported that 26 patients with increased serum uric acid level are found out of 46 hypertension, that is 56%. And a study done by Rizwan Ansari, around 100 patients involved, out of that 51 male and 49 patients, average around more than 65% showed hyperuricemia. Conclusion: in the study, a total 93 newly diagnosed essential hypertension patients were included. Out of that, 52.7% have associated with hyperuricemia. This study confirmed that the relationship between serum uric acid level and blood pressure, hyperuricemia and hypertension is quite different in age group. Among the hyperuricemic patients, female proportion was predominant, and 41 to 50 age group was common. The present study indicates that specific age gender group which would obtain maximal benefit from treatment of hyperuricemia to prevention and treatment of hypertension. Statistically, a significant correlation was seen between serum uric acid level and systolic blood pressure. Therefore, serum uric acid measurement aids in support and diagnosis of newly diagnosed essential hypertension in middle age group. Thank you.
Is open for discussion. Any questions?
To say on the diagnosis of
Newly diagnosed hypertension. Yes, sir. Yes, my topic is like just to show the correlation between hyperuricemia and hypertension. Because if you control the hyperuricemia by giving drug like which reduce the uric acid, you can control hypertension, and like possibly we can control related risk factor like CHD and any stroke.
That is the case we can do uric acid level and screening that.
Yes, sir. Yes.
Can prevent the occurrence of hypertension.
Yes, sir. Yes.
This is your thesis.
This is true.
23 years.
Total 93 subjects.
Most of the time, diabetes do
No, because it is not cause for secondary hypertension. That's why we have included, man. Around 1/3 patients were diabetic.
It is not that all hyperuricemia patients have hypertension.
No, sir. According to our study, only 53% correlation we have found, and mostly.
More clinical practice is coming from many cases.
Yes, sir. Yes, sir.
Not there in
Yes, sir. That is not related to hypertension.
Any genetic background?
No,
Have
sir.
you explored any genetic background?
As such, no, not like previously, no study has explained, sir, any genetic role.
Hypertension, blood genes are there.
Yes, sir.
And we are getting in relation to hyperuricemia with hypertension.
All the tests are performed here.
Yeah, in our lab only.
Thank you. Dr. Chetan, PG in medicine, the chief hospital present. His title of poster presentation is rate idiosyncratic reaction of phenytoin with and carbamazepine.
Good evening, everyone. My e-poster topic is a rare idiosyncratic reaction to phenytoin and carbamazepine under the guidance of Dr. V.G. Warren. According to as clinicians, we use most of the drugs as phenytoin and carbamazepine in most of the seizure disorder, especially in case of GTCS and in case of focal seizures. And since we have come across one case, that is an 18-year-old female came with the complaints of she is referred from a government hospital to our hospital with complaints of fever since 1 month and persistent nasal bleeding since 7 days. When she came to our hospital, she is having a pallor and with the nasal pack was inside too, with soaking was present, and she was not having other this thing like a cyanosis or any interest was present at that time. And when she came to our hospital, when we examined her, we got to know that she is a known case of seizure disorder since 6 years, and she was on tablet phenytoin 100 mg BD and tablet carbamazepine 200 mg BD. When we got to know, when we examined further, there was no history of any trauma or no history of any blood in stools or hematuria, or she was not a known case of any young hypertension or any case of type 1 diabetes mellitus. So when we got her investigations on the first day, the WBC and on a clinical on examination, gingival hyperplasia was present. On first day exam, CBC was showing WBC counts of 540 cells per centimeter, and in which neutrophils are just 1.8%. Severe neutropenia was present with lymphocytes of 96.3%, with hemoglobin of 4.5%, and platelets showing 5,000, and peripheral smear was showing pancytopenia, And serum bilirubin, initially when she came, it was 0.6 milligram per deciliter. After 2 days, when we got the repeat, the serum bilirubin was increased to 2.6 milligram, and in which conjugated is 2.1%, and SGO2 is 73, and SGPT is 263 units per. And we got done our hepatitis, HBsAg, HCV, hepatitis A, and HIV all came negative. We got her a fever profile in which rickettsial, brucella, in case of Vidal, everything came, dengue, everything came negative for her. So her fundoscopy was showing bilateral anemic retinopathy, and bone marrow aspiration was showing dry and this one hypocellular bone marrow suggestive of aplastic anemia. So blood culture we have sent, it is isolated and it is E. coli, and CT brain we got done for showed leptomeningeal enhancement in the parasagittal region of left parietal lobe, suggestive of focal meningitis. We got our ferritin levels, it was less than 0.5 microgram per ml. So this female was treated with empirically with broad spectrum antibiotics, antifungals, and antacids, IV fluids, injection tranexamic acid, injection vitamin K, and injection levetiracetam. And granulocyte coronary stimulating factor is advised in case of few articles we have started for her, and even blood transfusion was done, and ferritin and carbamazepine was stopped. But on the 4th day, patient became breathless and went on mechanical ventilator. Even after the best efforts, the patient was collapsed. So our discussion part is the ferritin and carbamazepine are the most commonly used drugs in case of among the clinicians, but it is one of the rare idiosyncratic reaction which causes, it is a myelodepression, which is usually seen with the post chemotherapy patients, but it is very rarely seen with the ferritin and carbamazepine. So in such cases, early diagnosis, hygiene, isolation, and proper hydration is the key in such cases, and broad spectrum antibiotics, antifungal covering is a must in such cases. For prolonged drug-induced myelosuppression, treatment option may include immunosuppression using high-dose corticosteroids, cyclosporine, or bone marrow transplantation. So conclusion is cautious use of ferritin and carbamazepine is needed, and if such cases we come across, we should do early diagnosis, timely discontinuation of the drug, and proper management is the mainstay of the such case of drug-induced myelosuppression. Thank you. It is a known adverse effect, but it is like idiosyncratic. It won't cause. It was easily not got to know because of these drugs. The myelosuppression is happening, but it is a type B type of idiosyncratic where the cause will be known later. Not in case of cytotoxic chemotherapeutic doses, what we give, they're all type A idiosyncratic reaction. In that we know that it can happen, myelosuppression can happen, but in such cases we don't know. So it is a combination because carbamazepine, when we give it the ferritin, its mechanism it will act more actively than we give single dose. So it both will cause a bone marrow suppression. So and chronic use is there, so it may be causing. It is around 2 to 3%. Oh, thanks.
It's only a comment. Okay. I thank all the members for attending today's meeting. And now I request our chairperson to kindly award the certificate.
One question.
Suggestion, comment.
Patient
Suggestions. You want to comment on this? Yes.
Yes, sir, it is given in the textbook that every 6 months we should look after the hematological and clinically we should examine the patient, and the hematological and liver function test we should get done, sir.
patient on long-term anti-convulsant therapy,
Yes.
immediately you have to get a
Yes, sir. We should get to know that she's whether the seizure fit is she's from or he's from, or we should get the hematological this way.
So I request our chairperson to